Okay, I wanted to welcome everyone tonight. It's a great turnout. What we're going to be doing is discussing the anterior total hip replacement, which is a procedure that I've been doing for the past year and a half. And I just wanted to go through some of the advantages and why I decided to start performing the anterior approach. Just in a little history, I've been in practice over 30 years. I've been doing the posterior approach for the past 30 years. What got me interested in the anterior approach was the fact that about 3 or 4 years ago, one of my colleagues had a hip replacement done down in Philadelphia from a posterior approach. He was out of work for 12 weeks. A year after that, had his second hip done with an anterior approach and was back to work in 2 weeks. And I thought that that was pretty significant, and that's what got me interested in looking at performing the anterior approach. So we're going to talk about some of the treatment options for hip arthritis. I just want to go through some of the anatomy so that you can understand what we're talking about. Anatomy of the hip, it's a ball and socket. The ball is the femoral head, and I don't have a pointer, and I apologize. The ball portion here, the socket being right there. Next slide. Okay, and what's causing pain? Over 70 million people have some form of arthritis throughout the United States. Osteoarthritis, which is wear and tear arthritis, is the most common cause of arthritic joints. Rheumatoid arthritis is probably the second leading cause of arthritis in the general population. And this is an autoimmune disease that attacks the lining of the joints, and then that subsequently destroys the joint. Next slide. What arthritis is the healthy hip normally has it's a ball and socket. There's a nice smooth surface on the end of the bone that allows the joint to glide smoothly. When you develop arthritis, what happens is you start to wear away the cover on the bone, and you can see that you've got holes where the cartilage is gone, and you have bone on bone, also developing bone spurs on either side. Okay, Jess, next slide. Assessing pain, a lot of patients will limp. Patients are unable to do their daily tasks. It limits activities and lifestyles. Patients stop walking, stop doing the sports that they like to do. Many times the leg will feel shorter because as you wear down the cover on the bone, the leg actually does get shorter. It may cause trouble with balance. It'll cause pain in the thigh, groin, radiating down to the knee. Classic hip arthritis is groin pain, thigh pain, radiating down to the knee. Treatment for hip arthritis, normally when I see a patient in the office, we usually will recommend a conservative program. And that usually indicates medications in the form of analgesics, which are pain medication. We'll recommend anti-inflammatories if the patients can tolerate them, if they don't have a history of ulcers or don't have a history of heart disease. We recommend intra-articular injections of cortisone into the hip joint, which can many times be very effective. If those are beneficial, I tell the patients that we can repeat those every 3 months indefinitely and try to save the need for a hip replacement. Physical therapy, water therapy, soaks and hot packs, physical therapy in the form of attempting to lose some weight, increasing range of motion, and increasing strength in the hip. Now, what a hip replacement is, these are implants that replace the ball and socket of the hip. It helps relieve pain, improves mobility, and over 270,000 are performed every year. Now, what is a hip replacement? As we saw before, the hip is a ball and socket. When we do a hip replacement, we replace the ball with a metal ball or a ceramic ball. We put an implant down inside of the thigh bone, and then we replace the socket. Okay, here's another picture of it again. This is the stem going down inside of the thigh bone, the ball portion here, and the socket which we insert into the bony pelvis. Now again, this is just an x-ray. You can see how instead of it being nice and smooth, there's arthritis, there are bone spurs all around here, and this is a post-op x-ray about concerning the total hip. You can see the femoral component down in here, ball here, and this is the socket. Now you may wonder how we fix these to the bone. We don't use any bone cement. And now these are press-fit prostheses. For the femur, what we'll do is we have special reamers that we can ream into the thigh bone, and it's like a press fit. It's like putting a 5mm dowel in a 4mm hole. It's tight. And once that is implanted, the bone will grow into the prosthesis, and it will become well fixed. The socket is the same way. What we'll do is we'll take the socket. We have special reamers. They look like cheese graters. We'll go in and ream the socket, and we'll ream the socket to 53mm, for example, and then we take a socket that measures 54mm, which is oversized, and when we pack it into place, it locks it in place, and the bone will grow into it. Sometimes, if we don't get good fixation with a socket, we'll put screws in through the socket into the bone to hold it. Okay. Now, minimally invasive surgery, which is what we're talking about, may lead to a shorter hospital stay, may reduce recovery time. Usually we use a 3 to 4 inch incision for this. The scar is smaller, less noticeable, and most patients can wear their bikinis back to the beach. The long-term effects and success of this approach are still being studied. So we really can't say that this approach is a better approach than other approaches until the studies have been done. It usually leads to less blood loss. There is potentially less disruption of the muscles and tissues and less pain after surgery. The benefits, again, just to mention that, smaller incision, less trauma to the body, quicker recovery and healing. What patients have had to say following this? There was a study recently, 600 patients who chose hip replacement. 96% had excellent results. 90% returned to their favorite activities. Now we'll talk specifically about the anterior approach. The anterior approach is a minimally invasive procedure, 3 to 4 inch incision in front of the thigh. As you can see right here, we don't remove any ligaments or tendons from the bone on the way in, and therefore one of the big complications after hip surgery is dislocation of the hip. That's one of the big concerns, is an unstable hip, that the hip can dislocate spontaneously. With this approach, because we don't remove any ligaments or tendons from around the hip, the incidence of dislocation doesn't go away, but it drops to less than 0.5%. Okay, so that's been one of my first questions that I always ask my PAs when I get back from a vacation is, did any of my hips dislocate? That's one of our biggest concerns that we worry about. So it doesn't go away, but the incidence is way, way down. The surgeon can work between the muscles and tissues without detaching them from the hip or the thigh bone. And we use a special table called the HANA table so that we can use x-ray throughout the procedure. Next slide, see if there's a... Okay, traditional surgery, patient lies on his side, the incision is on the side or the back of the leg. Muscles and tendons have to be detached to get into the hip joint, and the surgeon relies on post-operative x-rays to check for component position. With the anterior approach, this is the special table that we use. The posterior approach, which I used for 30 years, is still probably the most widely used approach in the world. Probably 90 to 95% of all surgeons still use a posterior approach. I'm just going to give you some of the reasons that I decided to use the anterior approach from posterior approach. First of all, we use a special table called the HANA table. We put the patient in boots. Okay, they're like little ski boots, and they're attached to the table. The difficulty with the anterior approach, the downside of the anterior approach is really to us as surgeons. It's a technically more demanding procedure. Okay, and on this table, the difficulty in the procedure is exposing the thigh bone when we're doing the surgery. This has a special bar with a little hook here that's attached to a hydraulic lift, so that when we're doing the exposure of the femur, the hook goes behind the femur, we elevate the hydraulic lift and it elevates the femur out of the bone. The advantage of using the HANA table is that we can do this with a live x-ray machine, and so that we can watch the position of the components as we're implanting them in the body so that we get them in optimum position every time, and that is the most important factor in the longevity of the hip. Second thing is, we can determine leg length at the time of surgery. One of the other potential complications that we worry about after hip surgery is leg length discrepancy. I tell all of my patients that I can make them a basketball player if I want after the surgery. I mean, we can lengthen them 2-3 inches, but we don't want to go there. So with the live x-ray machine, we measure the bony landmarks on each hip. And we can actually, we've been on right on 99.5% of the time. Okay, if there's a discrepancy, it's usually a few millimeters. If it's a little bit more than that, we may need a lift, but we spend almost as much time on leg lengths as we do on the procedure itself. Okay, next slide. Again, the potential benefits: less trauma to the body, smaller incision, less pain, less tissue disruption, fewer restrictions during recovery. Complications from the surgery. Just like any operation. Number one being infection. Okay, our infection rate is less than 0.5%. Dislocation, less than 0.5%. Blood clots, we usually place patients on anticoagulants post-op to help prevent against blood clots. Leg length discrepancy, we just talked about that. Big deal. There's nothing worse than having a young lady come in with a leg length discrepancy who wants to wear heels. Okay, and that's a big deal. And we spend a lot of time on trying to avoid that. Fracture. Anytime we place the femoral component down inside of the thigh bone, we talked earlier that we use a press fit. Sometimes we can develop a crack in the bone. Now that's, again, less than 1% of the time, but if it happens, we put a cable around the bone. It won't affect the outcome. The only thing the patient can't do is put full weight on it right away. Okay, damage to the nerves and vessels. Next slide. Post-operative course. Normally, if the patient is done early in the day, we'll get them out of bed the night of surgery, get them up walking. No dislocation precautions. With posterior approach, when I used to do that, the patient couldn't ride in the car for 4 to 6 weeks. They had to sleep with a pillow between their legs. They had to use an elevated commode. They had to watch the position of the hips so that they didn't dislocate it during the first 6 to 8 weeks while the new lining was forming. With this approach, there are no dislocation precautions, no pillow between the legs, so they can sleep in any position, full weight bearing. They can go to a cane as soon as they feel comfortable. They can drive immediately and ride in a car as soon as they feel comfortable. As far as work goes, if they have a sedentary job, I had one lady, I did her on a Wednesday. She returned to work that following Monday. And you know, so sedentary work they can get back to as quickly as they feel up to. Now that's unusual. I mean, most patients don't feel that good that quickly. Usually if it's sedentary work, 1 to 2 weeks they can return to work. Heavy work, 6 to 12 weeks. If it's manual labor or if it's construction work, we still have to let them heal and they have to give it time before they do the heavy work. Usually discharge 1 to 3 days post-op. Physical therapy 4 to 8 weeks. Usually with the posterior approach, at least in my experience, physical therapy usually ran about 10 to 12 weeks. With this, it's 4 to 8 weeks. So the physical therapy requirements are a little less. In summary, the leading cause of hip pain is osteoarthritis. It is degenerative, won't get better, and may get worse. Early diagnosis and treatment is important, especially if we want conservative care to have a chance to be effective. Hip replacement relieves the pain and improves mobility. Many patients have restricted motion in the hip because they have bone spurs all the way around the hip and they can't move the hip. And this will increase mobility, increase function. And as far as which surgery is to be performed, that's up to us, obviously, to help direct you and guide you from that standpoint. Good, thank you. Now I'll open up the floor to questions.
What determines from an MRI which the anterior or the standard procedure would be better?
You don't have to have an MRI for that. Okay, I'm doing the anterior approach on anybody who comes in who needs a hip replacement. The only thing that precludes doing an anterior approach is a patient who is morbidly obese, has a big pannus that comes, a lot of patients who are morbidly obese, their abdomen will come down and sit over their thigh, and then I can't get to the area. So those are the ones you have to do up on your side. The abdomen will fall to the front, and then you can work back here. But from the front, if you're going to do an anterior approach, that's the only contraindication. In other words, that's the only patient that we won't do. So an MRI won't determine that. The only other thing that we won't do an anterior approach is any patient who has had a multiple trauma to the pelvis in which they have plates and screws holding the pelvis together in the back, because in that circumstance you have to go from the back to remove the plates and screws.
Which hospital do you operate out of?
We operate here, upstairs, here at Coordinated Health. Yeah. Yeah, we do a lot of ours here, and I do some of our patients at Sacred Heart Hospital as well. But we have a full, this is a specialty hospital that does total hips, total knees, and we're dedicated toward aggressively rehabilitating our patients so that all of the physical therapists here are geared toward taking patients with total knees, total hips, total shoulders, things of that nature.
So there is therapy in this building?
Absolutely, yes.
And how many days does that take after the surgery?
Usually most patients are in the hospital 2 to 3 days. I've had a couple of patients go home a day after surgery.
Really?
Yeah, yes.
I read that there's some place where they don't replace the ball and joint.
Right.
They
resurface
it out,
they resurface it. There's a difference between that. A resurfacing procedure is a procedure in which you go in and you don't cut the ball off, okay, and you'll put a metal cap on the ball and you'll still replace the socket. Those are the large metal on metal prostheses. Those are designed mainly for young people who are very active and who want to return to full activities. Most patients who have hip arthritis are older, or not necessarily older. I'm doing a lot of people in their 40s and 50s now, but the demand on the hip is not going to be as great as for the resurfacing has higher complications. Okay, most people are doing very few of them. They have complications of developing interruption of the blood supply to the ball underneath the cap, which sometimes can cause failure. Sometimes they can fracture through the neck after the surgery. And if they have a good result from it, they have excellent range of motion, excellent stability, and they can return to almost near full activities. Okay, but in my practice, most patients are candidates for the standard total hip replacement.
How long does your anterior procedure take?
It usually takes about 1.5 hours to 2 hours.
Compared to what it used to, what was the old?
Well, the other procedure from the back was probably about 1 hour to 1.5 hours. So it takes a little longer. Technically, it's a little more difficult, but the benefits to the patients are spectacular. And again, I said I've done posterior approach, which is a great approach. I have excellent results through the years, but the post-op course for the patients has been dramatically changed with the anterior approach.
What is the pain like after you have the procedure?
Well, it's still painful, but the patients the next day, when I see them the next morning, have very little pain compared with the old approach that we used. And that allows them to get up and get walking much quicker and rehab much quicker. Yes?
That was probably the question I was going to ask. What kind of material do you use in your places? You've been reading a lot about these recalls.
Right. Well, the recall hip was one particular design. It was a DePuy ASR hip, and we're not using that. What would I normally use? I still use DePuy. Okay, that's been the company that I've been using forever. These are there are other companies that have great total hips out. I use a DePuy Karai stem, which is a titanium stem with a metal ball or a ceramic ball. Normally a plastic liner, a high density polyethylene liner, and a titanium. Right, exactly. Metal on metal. We don't use any metal on metal.
When you say ceramic, I mean, suppose you had a fall. When you say ceramic,
well, that's one of the issues. The issues about ceramic, and at least the first generation ceramic, was if you fall and it breaks, it shatters into 1,000 pieces. Okay, so when you go in to try to replace it or revise it, you can't get all the little splinters out. So that is one of the downsides sometimes of doing a ceramic head. Although we do them, and the newer ceramic heads have withstood exactly very durable at this point in time. So those are the options.
Yeah. Who determines that? The physician, or can an individual say, I want metal instead of ceramic?
Well, I usually do metal on plastic. I'll usually make that decision unless the patient has a strong feeling one way or the other. I've had some patients who are allergic to nickel, for example, and in that circumstance, the metal ball has nickel in it. It has chromium and cobalt. Then we'll use a ceramic head.
Is there an age limit, for instance, for this operation? Like if you're 80, for instance?
I just did, it's interesting you asked that. I did 3 weeks ago, on the beginning of the week, I did my youngest patient I've ever done, who was 17 years old, who had a horrible hip. I sent him to Philadelphia to see if they had any conservative procedures for him, and they said he needs a total hip. We could either do it down there, or I've operated on the family throughout the years. And 1 week later, I did my partner's uncle, who was an avid golfer. He golfs 4 or 5 times a week. He said, I'd rather be dead than live with this anymore, because he couldn't play golf, and he was 97. So it really depends on the health of the patient. I've got a lot of, I've done probably 4 or 5 people in their 90s.
What's the percentage of dislocations from the surgeries that you perform?
I've had none. Knock on wood. Whenever we talk about that, I know. So from the anterior approach, we've had no dislocations.
And what is the complications? If there is a dislocation, what's the complications to the patient?
Well, what happens is if the hip dislocates, that means the hip comes right out of the socket. I mean, that's an emergency. Patient goes right down to the ground. You can't walk, and it is painful. And usually you'll have to come to the hospital by ambulance, and you'll see us at the hospital. We'll have to put you to sleep to reduce it and pop it in place.
So it's all is just resetting?
Right. All we do is pull it back into place. But if it becomes an unstable situation, sometimes we have to go back in and revise it.
You talked about being able to drive. How soon afterwards?
You can, as soon as you feel good. As soon as you, if it's a left hip.
No, I'm talking about the right foot.
Oh, if it's a right hip, well, it may be a couple of weeks, because it's the right hip. You've got to be able to control your leg to get from the gas to the brake in an emergency. Maybe a little longer, a little shorter. Okay, with knees, for when we do total knees on the right, usually 3 to 6 weeks to regain your reflexes to get from the gas to the brake. Okay, but as soon as you feel comfortable, I tell patients I'll do them on a Tuesday, they'll go home on a Friday, and I tell them, look, if you feel like going out to dinner over the weekend or next week, you can, as soon as you feel comfortable, you can go out and do that, whether you ride or drive.
Do the conservative treatments like shots, do they really work? Or
oh, yes.
Postponing it?
No, well, you're postponing. They're Band-Aids. They're Band-Aids. I mean, if you've got an advanced arthritic hip, it most likely will come to having a hip replacement at some point in time. But a lot of patients are young. They don't have time right now. They want, and if we can keep them going, the injections do work. I have a number of patients that I've been injecting for several years who have done well.
What is the injection?
Cortisone.
course.
It's a Depomedrol cortisone injection. The Depomedrol is an anti-inflammatory that works directly in the joint. And that helps quiet it down.
I was actually in here with one of your doctors, and we talked about the shot, but he said he couldn't do it because he needed a machine to...
Yes, all of our injections are given with an X-ray machine. Okay? In other words, we do them with what we call an image intensifier. The knee we can inject, that's easy. It's right on the surface. Shoulder we can inject, but the hip is deep. And in order to make sure that the hip injection is in the right place, we usually give the injection utilizing the image intensifier, which is a live X-ray machine, to make sure that the needle is in the hip joint.
And that's here?
That's here. Yep, we do that here.
And the last question I have is, you said the surgery is about an hour and a half to 2 hours?
Yes.
Isn't that a long time to have X-ray on?
Oh, no, X-ray is not on all the time. X-ray is not, good question. No, we use spot X-rays. In other words, what we'll do as we're putting the component in, I'll have them shoot an X-ray that takes a second. Okay? And then I'll impact it in place, and then when I'm almost done, I'll have them shoot another. So total X-ray time is probably a minute, minute and a half total. If that sometimes.
I had 2 injections already. How many can you have?
The injection, you can have them indefinitely. Every 3 months indefinitely, if they work. If they work.
Where the pain is.
Yeah, where the pain is, yeah.
Sometimes they don't work after 3 times.
Well, exactly. Sometimes they don't work. That's when they stop being beneficial, that's when I ask the patients, I say, you know, 2 choices, live with it or fix it. At that point, because there's nothing else that I have to offer for them. So.
Is this new procedure more expensive, and does Medicare pay for it?
No, it was really not a new procedure.
Well, the one that you're doing.
The one I'm doing, no, it's the same procedure as any total hip. There's no extra charge for it. It's the standard reimbursement from Medicare.
Okay. And how long does the posterior approach take then, the surgery?
About an hour and a half.
So about the same?
Well, no, it's a little long. The anterior approach is longer. A little bit longer. Okay, there's no question about it. But I just felt that it had advantages over the posterior approach for both the patients, and the biggest advantages for the anterior approach, I feel, is the fact that we can use a live X-ray machine. I can watch the position of the components that I'm putting in and get them in an optimum position every time. That's the most important thing in the longevity of that hip and how long it's going to last for the patient. Second thing is I can be reasonably comfortable that my leg lengths are going to be right on every time.
Do you know, or do you believe that if something like a nutritional supplement like glucosamine or chondroitin would be of any value in this?
The chondroitin sulfate glucosamine, recent studies have shown that it probably is not significantly beneficial for the patient. The thing that has been good is the omega-3 fatty acids, the fish oil. That's been shown to be beneficial.
Thank you.
From that standpoint.
What procedures are there before the operation, like to determine the measurements and so forth?
In what respect?
Well, are all the prostheses the same size?
Oh no, we're like an auto parts store. When we're doing the surgery, we're in there, and we preoperatively we have special X-rays that we take that we template. In other words, we have computerized templates that we can get a pretty good idea of the size of the socket, the size of the femur that we're going to need. But in spite of that, once we start, the way we do it with the, for example, if we template a socket that looks like it's 56 millimeters in diameter, we'll start reaming at 52, 53, and I can actually watch myself with the live X-ray machine, and I can feel whether that fits or not. And then I gradually enlarge until I get to a point where the cheese grater engages, and I can tell that that's the size we're going to need. So we have a whole slew of different sizes. With the femur, again, we template it so we know preoperatively within 1 or 2 sizes what size we're going to need. Then we start out with our smallest broach, where we'll broach into the inside of the canal, and we gradually increase until the broach that we put in doesn't turn anymore. It's in there solid, and then we know what size we've got. So we have multiple sizes that will accommodate any size bone, female, male.
And that takes place all at the time of the operation?
Preoperatively, we do the templating, and at the time of the surgery, we do all that. We determine the exact size that we need.
From the time, suppose someone came into your office and you examined them and said, you are a candidate for a frontal operation. What is the time frame from the time the patient and you decided that he was ready for the operation until the time that you actually operated?
Well, it depends on a couple of things. It depends on the patient's schedule, when they want to do it. You know, I'll ask some patients and say, you know, you've decided to do it, when do you want to do it? And they'll say, I want to do it yesterday, okay? I'm usually booked about a month, month and a half out.
You're surgical?
Surgical, yeah. So usually about a month and a half in that neighborhood.
How would you compare a knee to a hip in terms of recovery time, pain, etc.?
Knee's a little tougher. Knee is tougher, yep. The knee, you don't have to worry. The complications from the knee replacement are different from the total hip. Total hip, the biggest thing we worry about is dislocation, leg length discrepancy. Those are the big things. With a total knee, there's no leg length issue because the ligaments dictate what you're going to, you know, how long it's going to be, so you can't lengthen. And there's no issue with dislocation of the knee. So from that standpoint, those two complications go away. But the rehab's longer, it's more painful, and it's a tougher rehab, just in general. Any other questions?
How would you proceed if you've had a bone scan and the hip is bone on bone? It's definitely candidate for a hip replacement. But there also could be a problem with the lower spine.
Another great question. We have this dilemma all the time. Patient will come in with an advanced arthritic hip, having some groin pain, but also thigh pain, but also has spinal stenosis, which can mimic the symptoms of an arthritic hip. And one of the things that and I tell my patients many times, I say, look, what I don't want to do is replace your hip if most of your pain and symptoms are coming from your back. So what I'll do is I'll send the patient to see one of our conservative spine docs, and usually recommend that they have some epidural injections. And I tell them to make note whether the epidural injections get rid of the pain. If the epidural injections get rid of the pain that they're having, then most of the pain is coming from the back. If it doesn't, then usually we can assume that it's coming from the hip. The other thing that we'll do is try a hip injection, intra-articular injection, in which we always use cortisone with Novocaine, with xylocaine. And if that makes the pain go away in the hip, then we know that most of the pain is coming from the hip joint, because what we've done is numbed up the hip, in essence, and that has decreased the pain. So we're trying to make a decision. That's a tough decision for us to make. The last thing we want to do is replace your hip and then your pain is no better. Any other questions?
What are the side effects of the cortisone injections?
Really not much in the way of side effects. If you have them every 3 months and don't have them too frequently, no side effects. If you have them every 2 weeks, a lot of side effects. Most of the side effects that you see from cortisone are people who take prednisone, and they're the pills. Then you'll have side effects from the pills themselves. The side effects, if given too frequently, is that the cortisone will interfere with the nutrition of the joint and can cause the joint to deteriorate. The problem is, I tell my patients most of the time that by the time we're doing a cortisone injection, their joint is already worse. You know, is it going to get worse? They always ask me, is the cortisone going to make it worse? I always tell them, look, it's already worse. So we're not going to be able to make it any worse from that standpoint. If you're diabetic, you have to be careful, because that could raise your blood sugars for the following couple of days. And I always caution my patients that if their blood sugars are unstable, then we'll hold off until they're stable. Otherwise, they'll usually go up to 200 maybe for a day or two, and then it'll come back right down after that. Very good. Any other questions? Good. Yes.
Do you always do the total replacement? I've heard somebody that had just the ball done, and then a year or two later they had to go back and have the other thing.
That's for fracture. We normally will do a partial hip replacement for people who break their hips. In other words, they'll break the ball portion of the hip off, They usually don't have any arthritis, and it's what we call a hemi-arthroplasty, meaning we're just replacing half of the joint. So we do that primarily for fractures. For hip arthritis, 100% of the time do a total hip. Always replace both sides. Because of that very reason. Because of that.
The liner also.
Oh, the liner also, yeah. For that very reason is that they can wear the hip down, and long term, you know, 3, 4, 5 years down the road, they can wear down the socket and they'll need to have a cup replaced. So we don't do that.